So let's talk MCI. Before I talk about the station itself, let's talk a little bit about the system we use for Regions EMS, because you guys are going to have to explain it to people. We talked about a year and a half, maybe a little bit longer ago, about how we were going to be changing up our triage system. And at the time, we changed to SALT triage. A few months after we did that, the docs found a new system that they really liked. That's called RAMP Triage. If you look in your guidelines, RAMP Triage is the triage system that we're supposed to be using in the East Metro. So I want to make sure that we're all on the same track when understanding it. So if you open up your guidelines, you'll see big bold writing, RAMP Triage, and the explanation of it, and I'll go over that with you in this video as well. The sentence above where RAMP Triage starts specifically mentions that SALT and START are only in your guidelines for use of interoperability. So you guys get called mutual aid to a West Metro service who happens to follow SALT triage. If you are asked to assist with triage, you would probably be expected to follow their guidelines. So that's why it's written down in your guidelines how to do SALT or START. Not because you're doing it if it's your call, but because you might help other services where it's their guidelines to follow those other triage systems. Let's talk RAMP. RAMP is one of the easiest systems for us to utilize. If we look globally, there are over 20 triage systems available. Some of them have over 5 or 6 categories for patients. Some of them have 2. In fact, the easiest one that I found so far is patient is red or patient is dead. So they're emergent or they're not leaving the scene. RAMP doesn't quite go that far, but it makes a binary decision fairly easy for us of transport or no transport. Here's what we're looking for. I show up to an MCI, and we'll talk about what an MCI is in a second here, but I show up on an MCI. I go to triage my first patient. I am seeing if the patient can follow commands and if the patient has a peripheral pulse. If the patient can do both of those, right? Follows commands, has a peripheral pulse, patient is green. If patient either cannot follow directions but has a pulse, or has a pulse but can't follow directions, that patient is red. If the patient can neither follow directions nor has a peripheral pulse, that patient is expectant or dead. So we have green, red, black, and that's it. Now it seems harsh coming to that because we're used to having lots of decision-making and critical thinking when involved with MCI triage. RAMP's goal was to get rid of that because in a true MCI, you're probably going to be overstressed and it's going to be tough to do true critical thinking with every single patient. Here's the data behind RAMP and why we're moving to it. So let's look at 2004. Study done in trauma level 1 hospital. They're trying to determine if there was a way pre-hospitally where we could determine likely outcome of patient. So for example, I have a patient in a car accident. Should I be transported to a level 1 and are they likely going to get a surgical suite, stop in the ER, go to the OR, go to the ICU, etc.? And what the study looked at was what can they correlate closest to an injury severity score, which is what they use in hospital. And the study found 2 things. 1, GCS is a great indicator. They also came to the recognition that GCS is very difficult to do on every single patient, especially in an MCI. So they looked at something else. Glasgow motor response, so the ability to follow commands or not, had an almost equivalent outcome in patients who had a poor total GCS. If you remember when we talked trauma, probably last year, your TTA requirements are a GCS less than 13 as one of the things in that category. But we correlated that if a patient in the Glasgow motor response was less than 6, the highest you can get in that category, they had equivalent outcomes to patients who had a total GCS less than 13. So if I show up and a patient cannot follow a basic command, patient has a GCS less than 6, patient is a red patient. Because I can't take the time during MCI to find out why the patient can't follow directions, nor is that my goal yet. My goal is to say, can you follow directions and do you have a peripheral pulse? And if the answer is yes to one and not the other, they are red and they have to go emergently. 1995, so older study. What they found was disagreed with the 2004 study. So this was a study of about 30,000 patients. It was a multivariate study. And what they found was overall best indicator of survival from trauma was a patient's ability to follow basic commands. And if they could not do that, most of them had poor outcomes. Why we check for peripheral pulses. Pre-hospital trauma patients presenting with absent radial pulse had an overall mortality greater than 50%. Patients without peripheral pulse secondary to trauma do not often do well. There's a few more recent studies that have shown post-traumatic event, severe internal bleeding, especially with hypotension. Every minute that patient is into the OR, they lose a 2 to 4% chance of survival. Every minute. When I say peripheral pulse, you can do radial, you can do femoral. So if I have, and the reason that we can do both is that there's been some recognition that depending on patient meds, depending on temperature outside, depending on our nerves, we may or may not be able to feel a radial pulse extraordinarily well. So a femoral is also appropriate or reasonable to assess for. Carotid doesn't count. That's a central pulse, so that's not what we're looking for. Now, of course, after these two separate studies came a study that put this all together. In patients that have lack of radial pulse and are incapable of following commands, that's 2. I know the camera isn't catching both fingers. 92% mortality rate. Those patients have an 8% chance of survival if they get to trauma OR immediately. In a true MCI, we don't have that opportunity to do. On the flip side of the coin, patients who had trauma, positive radial pulse, and followed basic commands, 95% survival rate. Those are the patients we need to focus on, the ones we have the best chance of surviving this. If we talk about EMT and medic textbook MCI, any time that I have to call additional resources, I'm on a mass casualty incident. I go to a 4-vehicle pileup. I'm the first truck on. I have to call for 3 extra crews to transport everybody in a reasonable amount of time. The book would say I'm in an MCI. I will argue, as well as the docs will argue, that is not the time to start pulling out RAMP Triage. If you have the resources to transport every single patient off of that scene, and really you're just deciding who goes first and who goes last, this isn't a true RAMP Triage MCI. This is I have to make a decision on who is most emergent versus less emergent, but everyone's getting transported, and they're probably all getting transported within 20 minutes. What RAMP Triage is more used for are those very rare events. You have 50 patients, you have 60 patients, you have 100 patients. And you have to get through all of them in a reasonable amount of time and decide who has to go now, who can hang out for a bit, and who's probably never leaving this scene. And that's a difficult decision to make, but it's one we have to be capable of. Your guidelines need a mild update in the RAMP Triage flowchart. I'm going to include a PowerPoint, not one that I made, in the data for your trainers, and it shows a more up-to-date flowchart. It's a presentation by Brad Keating. Brad Keating is one of the co-creators of RAMP Triage. Just so you guys have background info, RAMP Triage was created for tactical medicine and military medicine. We're just adapting it for rural and urban EMS systems. So, the change in the flowchart is now directly prior to giving a triage color, we perform a life-saving intervention on those patients. So, here are the life-saving interventions that we should really consider. Open an airway, needle chest decompression, tourniquet placement. Wound packing if it's a wound packing, and obviously tourniquet won't work for it, and we have the equipment available for us. Outside of those things, we can't spend a lot of additional time with every single patient. We don't have the time to do that. That's why we're calling this an MCI. Now, In the presentation I'm going to give you from Keating, they do a comparison with START and RAMP Triage. I couldn't find a comparison with SALT and RAMP Triage, but there's a couple things that I really liked. One, triage accuracy, including both under and over triage, 84% for RAMP, 58% for START. So way, way better. In an additional study, when they did RAMP and what's called SMART triage, which is very similar to START, RAMP got up to a 98% accuracy. SMART was as high as about 76%. The other thing that was nice is RAMP was done a lot faster than most of the other triage systems that we've used in the United States, because it's, do they have a pulse? Can they follow directions? Can I move on to the next patient, or do I have to do any life-saving interventions? I'm going to create another video about kind of how to run this and stuff, but I just wanted to give you a little background with the information about RAMP Triage specifically. So I'll see you in the next one.